keep you engaged. My name is Alice Weingartner. I'm with the Community Care Network of Kansas. We are the primary care association for the state of Kansas, and our members are federally qualified health centers, rural health clinics, and community-based clinics across the state. And of course, there's a little more information about us up on the screen. I have the pleasure of introducing our last speaker, Justin Duncan, who is the Chief Executive Officer of the Washington County Ambulance District, is a regional mobile healthcare system in rural Missouri. I've had the pleasure of getting to know Justin over the past year and a half, and the work that he is doing is incredibly impressive. Has anybody seen him before here? Oh, you got a whole new crowd, Justin. So, in addition, Justin is the president of the Missouri EMS Association. He's the chair of the Missouri State Advisory Council EMS, the Mobile Integrated Healthcare Subcommittee founding member of the Washington County MIH Network, and a founding member of Missouri Highlands MIH Network. He's a longtime advocate of EMS professionals, an ardent supporter of education, and constantly looking for new ways to bring innovative therapies into the out-of-hospital setting. He's a fierce advocate for mobile integrated health systems and is driving change to ensure EMS clinicians are recognized as healthcare providers. He's considered a disruptor in the EMS and healthcare worlds. He constantly pushes to advance EMS systems and strives to be a catalyst for change in the healthcare world. Above all else, he's a dedicated servant leader and strives to support those who take care of the ill and injured. He's also a collaborator who understands the importance of working with a diverse group of partners to figure out how to best address the needs in the community and to identify funding supports to support those efforts. Please join me in welcoming Justin.
All right, I have no idea who wrote that, but that is not me. So I am a paramedic by trade for 21 whole years. Before that, starting at the age of 16, I was a volunteer. I've literally done nothing my entire life. I hold licensure as a critical care paramedic, a flight paramedic, and as a community paramedic, on top of other things. I went to the dark side and decided to lead a land of misfits, and we try to do best by the ill and the injured. So before we get going, and I've got the thing here to start driving, couple of questions. I know that I'm the last thing between you and getting out of here. This is interactive. I don't generally follow rules and stay behind the podium. My ADHD kicks in and I start walking and wandering. So, how many of you think that if you call 911 right now, you are guaranteed for an ambulance with a paramedic to show up? Raise your hand. Okay, false. In 13 states plus the District of Columbia, EMS or emergency medical services are considered essential. 13. Kansas is not one of them. Missouri is not one of them. What that means is, if you call 911, there is no guarantee that anyone will show up. If they do show up, they may or may not be a paramedic. They may or may not be an EMT. They might be a volunteer. They might be coming from an hour away. In Missouri, we still have 8 communities that don't have 911, meaning you have to call the local sheriff's office and look up a number in a phone book to try to get resources. I've been a paramedic for 21 years. I can put you to sleep, put a tube down your throat, cut a hole in your chest, start blood products, put you on a mechanical ventilator, and I am not considered a healthcare provider by CMS. We are a service provider of transportation. That goes back to the 1970s and early 80s, and we have been unchanged since then. Outside of pilot projects, that means that my folks are not reimbursed unless we take you to a hospital emergency department, with very few exceptions. There are exceptions that are becoming more prevalent for treatment and no transport and treatment alternate destination. As I listened to the last session, y'all were speaking my language with crisis stabilization units and the importance of right care, right place, right time. And I'll talk through a few projects that you're seeing across the world. Another common misconception is that we render emergency care all the time. I know that I have a couple ER nurses in here, and I know Tammy's background. We trauma bonded for a while there, okay? 80% of the volume of my service for people who do activate the emergency system are primary or urgent care in nature. That statistic is conservative, meaning 20% of our volume is a true emergency. We, of course, always have heart attacks, strokes, trauma cases, broken bones, but the grand majority of what we do is, I ran out of my meds. I have a toothache. I just don't feel good today. My back hurts. My oxygen concentrator doesn't work. That's an all-time favorite of mine. And that system has been built because of the need for the safety net. And I think that's why I bonded early on with my FQHCs, in that we take care of everybody and we were designed as safety nets. When someone calls 911, I don't have the ability or the opportunity to say no, and there is no 912. So my folks show up. You gotta figure it out, right? It's like walking into a rural ER at 3 a.m. You don't have trauma on call. You don't have a specialty on call. You figure it out with the tools that you got and you move forward. So insert this thing called mobile integrated healthcare or community paramedic work. If we talk about MIHCP, and that's how it's gonna kind of flow off of my tongue here, it's been around for about 20 plus years, formalized, mostly around large hospital systems and bounce back admissions. And that was their original partnership. Hi, big hospital system, let's work to make sure that your CHFers don't bounce back. Let's make sure that your frequent flyers stay out of your emergency department, and we'll save you some money. Fast forward, and I spent a part of my life in the rural mountains of Colorado in communities that didn't have hospitals, and it was, well, do we need to take somebody with a stubbed toe an hour and a half to the nearest receiving facility, or can we treat them in place and keep them in their community and maybe do a follow-up with, say, an urgent care or with a clinic provider? And so then there was this mantra of, wow, that makes a lot of sense. Prior to the global pandemic in Missouri, we had 8 mobile integrated healthcare programs statewide, all urban. We were told it wouldn't work rural. And if you haven't met me, which most of you haven't, I don't like being told no very much, or you can't. And so we started the project because it was right for our community. I had a physician who shall remain nameless that comes from the big house, Barnes, WashU, downtown St. Louis, say, you don't have homelessness and you don't have these issues in your community. And I lived in the rural world my entire life, other than when I went to undergrad and decided that I would rather be in a community with more cedar trees than people. And I went back to the rural world and I said, come take a drive with me. Get off your stilettos, put on some tennis shoes and some jeans, and come take a drive. Have y'all ever seen a house with dirt floors? Have you seen a trailer with sewer running out into the ditch? Have you gone into that trailer that has a tarp for a roof and you have to watch where you step so you don't fall through? I consider that homelessness. You don't have to live in a cardboard box under a bridge to be considered homeless. So we have that unfair, unrealistic bias that urban centers are the only ones that have disparities and that have homelessness and have problems. We have the same problems, they just look a little bit different. We have resource deserts in rural, we have resource deserts in urban areas. We understand that. They just look a little bit different. So our model really kicked off during the pandemic. In the beginning, I'm a paramedic and worked in emergency care my whole life. So when the state says, we're gonna take care of you, you'll be fine, I'm immediately going, you're lying to me. We're not gonna be fine, we're gonna be on our own. So the pandemic said, we're gonna provide all the support we can give you. The state's got you. And we all went, yeah, right, okay, cool. All the money's gonna go to the big cities. Let's band together and let's have plan B. And then if they do come through, awesome, that's great. But we'll have our plan B in place. So we sat there and it was massive influx of patients. Let's get ready. And they didn't show up. We did a really good job of scaring people. Really, really good job. But what we recognized was our frequent flyers didn't magically get better, right? When you have a patient who calls you 150 times in a year and they are now calling you 0, they didn't just overnight get better. So we said, let's just go start checking on them. I had people sitting around with nothing to do. Let's go check on folks. And that's how we got started. So our 10,000-foot view of what we think is the appropriate MIH model that is being replicated across the state, replicated across the country, and recognized by HRSA is diverse, inclusive, whole person care. It used to be whole patient care, and then I was humbled. I am a community health worker. I didn't know what a community health worker was 5 years ago. I've been a community health worker for 21 years, where I had a friend who was sitting up here earlier who said they all have different titles, but they all do the same thing. I've sat at the table of a diabetic patient and talked to her about her disease process, her eating habits, and connected her to healthy resources. That's a community health worker. We utilize our CHWs hugely to not only treat the medical needs, but also the non-medical needs. I will still get on the soapbox and say, if you don't know where you're going to sleep tonight, you don't care what your blood pressure is. And if you don't know where your next meal is going to come from, you don't care what your glucose is or if you're going to have money for insulin. And so if we don't address those disparities or those inequities first, the medical, I can throw all the drug at the world at you. It's not going to do a damn bit of good, right? So we really embraced that whole person care model. And we didn't get care if we get called out to give you a flu shot. If we get called out to give you a flu shot, we're going to do an SDOH assessment. We're going to flip on your faucet. We're going to look in your fridge. We're going to do a med reconciliation. We're going to talk to you about, smoking cessation, a prepare tool assessment. When was the last time you had a primary care visit? Do you have a primary care provider? What do you meet criteria for? And sometimes they refuse all of it. And sometimes you catch them. And sometimes you engage someone in primary care. And that's the power of sitting at someone's kitchen table versus waiting for them to come into brick and mortar. And then let's argue, especially in our rural areas, do they have brick and mortar? Do they have a way to get to brick and mortar? And are they going to show up, even if they have all of that access? So our model utilizes a community paramedic and that is dual certified as a community health worker as an extension of the healthcare system that is within brick and mortar. When you look at our state, we had 8 systems prior to the pandemic. Now dotted across the state, we have programs. We were the first, I'm very proud, on the national level for an ambulance service to have a formalized relationship with an FQHC. It started with patient care. I now co-locate with them. We share a maintenance division. We share a medical director. We share a quality office. We do joint purchasing. But we don't only work with our FQ. We work with our CAW. I technically work with 2 FQs, 2 critical access hospitals, 5 rural health clinics, a whole bunch of local family doctors, public health departments, community partnership, re-entry council, drug court, law enforcement, anybody who will give us a referral or have a conversation. 988, I never dreamed we got our first direct referral from 988 to one of our community paramedic teams to immediately respond and not just send an ambulance with red light and siren or law enforcement to be able to ensure that patient gets the right care at the right place at the right time. Fast forward, we have 8 separate networks across Missouri that have some level of involvement with an FQHC. Our model is extremely simple. This is not rocket science. We take healthcare to the patient. We are the bridge and the glue. Like I said, we are very, I learned a few years ago that a provider could fire a patient. There's been a lot of patients I've wanted to fire over the years, but a paramedic does not have the right to fire a patient. So what you find is, you have the grumpy Gus who gets passed around from nurse prac to nurse prac to nurse prac, and we're going to just go ahead and call him Sam because he's one. And when Sam, you don't treat the nurses like garbage, okay? You're gonna be nice to the nurse practitioner. right? You can call me whatever you want, don't care, but you're gonna be respectful, all right? Because we're gonna just keep coming back. So we might as well figure this out now, right? That's our normal mentality. A paramedic is licensed in Missouri as a physician extender, so it makes my life easier in that I can be flow and protocol based. We were historically licensed as an extender of that ER physician or an ICU physician. Now we've just flipped it to a primary care model. We have telehealth available 100% of the time. And I don't know much about Kansas. All I knew about Kansas prior to going to Topeka for a conference and then to Wichita was it was the really boring stretch between Kansas City and the mountains, and it was really windy. When I left home yesterday, I felt like I was driving through fields, nothing. Hi, Wichita, how are you? So I'm gonna go out on a limb and say, do you have great broadband access across your state in every corner of your rural areas? No? Okay, cool. So my service area is over 1,500 square miles, and about, I can hit Reynolds County, and I can drive for 2 hours and not be able to get a phone call out. So am I gonna do a telehealth visit? No. So my SUVs sit in your front yard with satellite technology and everything in between. We have people that want to access telehealth, but they don't have the connectivity to be able to do so. So we bring that to you. I also bring a licensed clinician that can do diagnostics in your living room. I can do an EKG. My providers carry ultrasound. We have iStats. I can result labs in real time. We can draw blood. We can do swabs, vaccinations. And the beauty behind it is I not only can telehealth with a primary care provider, I'm worried about this person's mental health. Loop me in with an LPC or an LCSW. Can we do a real quick assessment? Or, hey, I'm doing a med rec and I have a question. Loop me in with pharmacy. And I'm not sitting at their kitchen table making these phone calls. I'm calling my community health worker and my comm center saying, I need a consult with this one, and this one. And they send out links and go, pharmacies on telehealth, go. LPC so-and-so's on telehealth, go. Primaries on telehealth, go. So we take that provider-centric brick and mortar model and we make it patient-centric by sitting at their living room table, and we remove the excuses. At dinner last night, we were talking about one of our vaccine hesitancy programs. We forced nothing on them, but we had honest education from people that they trusted. And folks said, why do people trust paramedics? I don't understand. And I said, well, you know, my passion is education, and that was my background. I never wanted to be the boss, and honestly, it's not a fun job being the boss. Everybody knows that. But I have to take a 19-year-old child fresh out of high school, and I have to teach them in an associate's degree program. So let's take them at 18 or 17, and I know what my mental capacity was at 18 or 17. And I have to teach them to wake up at 3 in the morning on hour 45 of a shift, drive somewhere they've never been before, be invited into somebody's home whom they've never met before, and convince and instill confidence in a mother to hand over their blue baby. That is my obligation. That's what we do on a regular basis. So if I can teach someone, and my providers have that level of trust, to sit and talk about a vaccination is just pretty simple. To talk about your diabetes is pretty simple. To say we care about you and it's okay to not be okay, and that we have lived experience of SI history, of suicide attempts. My industry has one of the highest suicide rates in the country. And having those conversations with people of no judgment, been in your shoes, been there, let's work through it together. That's the model that we truly believe in. So what I just told you in a story is now in a beautiful flowchart graphic that I clearly did not do because I only think in square lines, and I love Excel, but we really embrace the community health worker, and Kansas is ahead of us. Y'all got some reimbursement. We have none. We have a licensure, but there's $0 behind it. We utilize our CHWs not only, like I said, in the home, but in my communication center. I want my providers to be able to function at the highest licensure level possible, whether it's a nurse practitioner, a physician assistant, my community paramedic, my community health worker. So they do scrubbing of charts. They do the phone paperwork, the intake, anything that can be done. So I'm going to take care of Tammy today. When Tammy pops on my CP schedule, she's due for her COVID booster. She's due for her flu shot. She's a diabetic. She's due for her A1C draw, her eye exam, her foot exam, blah, 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 blah. I can tick all of those marks off in the moment. Hey, Tammy, Justin's coming to check you today. Are you ready for your flu shot? Yeah, sure. Sounds great. Okay. Not sure about COVID. Okay, well, he's going to bring it, but we'll have a conversation before we go down that path. And those are the things that the team brings together. It is a true diverse, no egos, break down the silos. We all put our pants on one leg at a time and take care of the sick people. Our vehicles, one thing that we heard is nobody wants an ambulance sitting in front of their house. Well, we don't send ambulances. I send an SUV that is very discreet. It has all the same cool stuff in the ambulance. You'll see a safe. Well, that's because we carried controlled substances. We carry buprenorphine. We also, all of my community paramedics are critical care paramedics first. So imagine in a very diverse area, they are often the closest person to a true life-threatening emergency, and they go and they stabilize until an ambulance can get there. They carry all the same equipment. They carry mechanical ventilators, BiPAP devices, cardiac monitors, ultrasound. The refrigerator you see there has the ability for blood and blood products, but it also has rapid swabs for RSV, for flu, for COVID, for strep. It has an A1C machine. It has an iStat that we use on the emergent side for an arterial blood gas on an intubated patient. But I can check your A1C and result it in your living room and really talk to you about your trends. We then have the ability to push that information to the provider. And just like if I was bringing Tammy a patient in the ER and give her a report on my patient, that nurse prac's going to pop up on the screen and I'm going to go, hi, Casey, who's one of our super supporters. I'm here with Mrs. Smith. We're due for our diabetic encounter. We've run through and done all of these things, but I just noticed she's got a decube on her right posterior. I'm kind of worried about it. I'm going to grade it. Do you want to take a peek? Yep, we can do that imaging in the moment. And then we can take add-on orders. You want me to culture that wound? Yep. Do you want me to throw an IV in and start broad spectrum antibiotics? Yep. Do you want to call something in for pharmacy and I'll arrange for a delivery before we leave? Yep. Okay, when do we want to schedule a follow-up? Are you good for next week because this wound's pretty nasty? Yeah, and let's consult with wound care prior to the next visit. Awesome. All that's done in your living room. And it was targeted as patients that didn't have access to get to brick and mortar, or they were the high-risk no-call, no-shows. How's your public transportation in Kansas in the rural areas? Non-existent, right? Same here. I hear it all the time. Well, call MTM and get a ride to the clinic. In my communities, I have one SMTS bus and that's about it. So they just don't go. So what do? They call 911. And where do we take them? The emergency room, because we are incentivized as a business to take them to the emergency room. I would love to take them to clinic. I can take them to clinic all day long. Ask me what my reimbursement is. 0. So the system of care and the model is designed to incentivize us to cost the most money possible. And then I'll argue if you're receiving primary care in an ER, you're not receiving primary care. And we've known that and we've proven that. Some common services that you'll see with MIH programs across, and I'm representing here the state of Missouri, but also as a local rural. I'm going to fight for rural to the death because that's just who I am and I don't care. And I like when people say you can't do something and proving them wrong. Chronic disease management, number one, what we do. Insert heart disease, insert diabetes, insert CAD. We make that telehealth available. In the beginning, what you found with your providers, they wanted a telehealth visit on everything because they were, Family practice doctors and nurse pracs, all they knew about us is we would show up when they had a real sick patient, and what we knew about them, and I hate saying this, but we thought our FQHC was the free clinic up the hill. And now years later, we know that we're all a whole lot different than that. And so the telehealth is available, and it's not just for the primary provider. I cannot stress that enough. The ability to bring in an LPC or an LCSW is amazing in the moment, or a pharmacist to help with a medrec, amazing in the moment. Yes, of course, primary care is absolutely important, but I never dreamed that we would be doing telehealth and facilitating those conversations with those other specialty providers. Care gap closures, in-home vaccinations. I'm a chronic disease patient. I have Crohn's. I'm supposed to go every 8 weeks for Inflectra. I'm supposed to drive 2 hours one way to St. Louis for my IBD specialist to get that infusion. I get it in my living room or in my office. Not that I don't have the means, but one, I want to support my local community. And two, that's a lot of lost time, and I have a vehicle. So imagine my chronic disease patient who lives in a community with no hospital, no clinic, no infusion center. They're just not going to show up, and we wonder why they wind up in the ER, why they wind up admitted, why they wind up in the unit. We've kind of created a system that's a little bit difficult to navigate. I would like to say that I'm not the sharpest tool in the shed, but I know the healthcare system a little bit. I went almost 4 months without my Inflectra because of an insurance change, just fighting pre-approval process. And if my case manager told me she was a bachelor's prepared nurse one more time, I was going to jump through the phone and choke her. But we finally got the pre-approval process done, and she said, "You have no infusion clinic in your community." "Yes, we do." "No, you don't." "Yes, we do." "You need to go to St. Louis." "No, I don't." And so we had this really nice argument back and forth that did not turn nice. And you can insert some other words here because I have a colorful personality. And I said, "Well, I run the infusion clinic as a part of my mobile integrated healthcare program, so I promise you that we have one." "Oh, well, they're not connected to Epic." Of course they're not. There we go. They're not connected to Epic. So you want me to go to the mothership. Let's just call the spade what it is, okay? You want me to go to the mothership for my infusion instead of supporting my community. How many of our normal patients are going to have that argument? They're going to just say, "Okay, my doctor says I have to go 2 hours one way." I was accused and told, "You're going to take home health jobs and you're going to take hospice jobs." We do more work alongside home health and hospice than I ever dreamed of. We get more referrals from home health and hospice than I ever dreamed of. There is plenty of work to go around, folks. We don't want to take anyone's jobs. I promise you that. 2 recent stories. One 7-year-old brain tumor terminal in our community, 3 hours south of St. Louis Children's Hospital. St. Louis Children's has an amazing palliative care program, an amazing hospice program. But that hospice nurse was based out of St. Louis, 3 hours away. What a better collaboration with local community paramedics who can just do spot checks and education and walk through, "We're going to have seizures. This is how you use intranasal Versed. Have you ever suctioned someone before? When do you need to get worried? When do you not need to be worried? If you're worried, just give us a call and we'll swing by because you're 10 minutes down the road, or we'll have someone pop in and just keep." And that child was able to die at home, which were the wishes of the family. Otherwise, the child likely would have been admitted to a facility and not been able to pass in the environment that they wanted to. We didn't save a life, but we in healthcare need to embrace quality versus quantity. And anybody who's worked in emergent or intensive care, we do a really good job of torturing people and forgetting that there is a quality of life aspect. And it's okay sometimes when someone's ready to go and to pass, to allow them to do it on their own terms, in the comfort of their own home, and to support them through it. Wound care, lab collections, we do lots of episodic things. We gave 18,000 vaccines in the first year after COVID came out. And I'm talking about a community of less than 40,000 people. And we had folks coming from far and wide. And they said, "How are you able to do these things?" And how do you manage the logistics? Well, we've been doing flu shot clinics for the last 20 years. We're just throwing a different drug in someone's arm. Literally, that's it. And we pushed it down, we forced it on nobody. We removed excuses. That was the conversation we had at dinner last night. Remove the excuse. I would get my shot, but I work during the day, and public health is closed. They work banker's hours. Awesome, I have people here 24 hours a day. Oh, but what about, can I come in on a Saturday? Nobody wants to see me on a Saturday. We're here on Saturdays and Sundays. We're here on Easter. We're here on Christmas. We're here on whatever holiday you want to dream of, good, bad, or indifferent. We're here. Throwing a shot takes no time at all whatsoever. I can't get to you. Cool. We'll come to you. I don't want you in my house. The front porch works. My front porch is going to fall off. Come sit on the back of our floorboard, of the tailboard of our truck. I mean, literally just remove every and if they said no, they said no. That's great. But we could sleep at night going, we removed every excuse possible. We had an honest education. It wasn't being shoved down their throat. And it was, did you get the shot? Sure did. Why? Because I believe in it, and I believe in a better good for my community and the world around me, and I think it's the right thing to do. Okay, put the shot in my arm. Having that very honest, sitting on your front porch conversation versus coming in to a facility and you're in and you're out. We do some things a little different. So we take the Prepare Tool assessment and we adjusted it. So if we identify a hazard, we identify a risk, we fix it. So, very fun one. You walk into the home of the COPDer who has 50 miles of oxygen tubing stretched across their entire house, right? Let's go ahead and shorten that up and let's shore it up and make it good. You don't have grippers, so you're falling off the toilet all the time. Let's get some installed. We had a gentleman who had a left-sided stroke, so his right side was his dominant and his strong hand, and on his ramp, his right-sided arm rail was broken and he was falling on all the time. Imagine how less he fell when we just built him a nice handrail to grab onto. None of this is rocket science. MedRecs. I will get on a soapbox now. We passed prescription drug monitoring in Missouri a couple of years ago. It is horrible. We have polypharm all day long and twice on Sunday. I'm sure it's not much different in Kansas. You have a patient who is prescribed the same medications by multiple providers. I'm going to talk about one of our most common frequent flyers. She was a well over 150 call for service a year patient. She was about 5 foot tall and 500 pounds. She had every comorbid under the sun that you could imagine, no family. Had a behavioral health background, behavioral health diagnosis, diabetic that was uncontrolled, et cetera, et cetera. She called for altered mental status and fell all the time. She would be transported to the hospital. Because of her comorbids, she was a full workup. She got admitted. She cost lots of money. Well, during her first visit on the med reconciliation, for my healthcare providers in the room, she had been prescribed Haldol 5 milligrams twice a day by 5 different providers. Haldol makes you sleepy. It's the sedative that we give our behavioral health patients. So she thinks she's being med compliant because she was prescribed this medication by her doctor, and we're sitting at her table going, well, no wonder she's falling all the time and she's altered all the time. A simple sit and do a med rec. Can you do a real good med rec on a 15-minute visit in a room? I know what I say. Are you taking all your meds? Yep. What are your doses? Oh, I don't know. I guess I would have to, let me get onto my chart really quick and let me see what my doses are. I don't remember those off the top of my head. This model was submitted to the Health Resource Service Administration, and I love this platform because I am housed by EMS at the federal level under the Department of Transportation, National Highway Traffic Safety Institute, or NHTSA. I have no direct pathway from a regulatory standpoint to any healthcare entity in Washington, D.C. We are housed under DOT. Sure, we get kind of shoved over, but HRSA, we threw this in as a primary care challenge, and we took the first place win. Our FQs, they see the synergy. They see it as expanding their service model. We identify as an extension of the clinic. We just wrote a HRSA grant, the after hours extension grant, and we said RCPs are the after hours extension of the clinic. We just provide a report in the morning. We're doing it today. We're initiating buprenorphine at 2 o'clock in the morning on a Friday or a Saturday and carrying those patients until Monday when we can get them into clinic with a MAT provider. We work on integrated care with the whole person in mind. We look at those care gaps. My business has looked at how quick do you get the STEMI patient to the hospital? How fast do you get that EKG? How accurate are you with your ventilator settings and your intubation success rates and your blood products? Now we're looking at it from a primary care standpoint. Are you initiating and treating these patients and making their care gaps look better? From the perspective of a paramedic, think of the burnout of running the same patient over and over and over and over and over, and you're not affecting their healthcare. You're just treating them episodically. And now you actually have the opportunity to track this patient through and watch them get better. I bring up this story here because what you see, if you read name tags, you see nurse practitioners, you see a physician, you see community health workers, you see a high school volunteer, you see community paramedics. Taking somebody who lived in a trailer with no running water, had not followed through to get enrolled for Medicare and Medicaid, had not been a primary, and worked her case for over 2 years. And this is them moving her into senior housing and the first stable housing she had had in her entire adult life. There was zero medicine involved in that right there. Zero. But after that process, we have her enrolled in primary care. She has stopped smoking. She is working with an LPC on understanding her history and her trauma. And it all started because a couple of people sat with her and said that we care about you. And 2 years of working a patient before we even start talking about a clinical quality metric. Now here comes the data nerd in me, okay? And I know that I can tell you stories all day long and we all love feel-good stories, but if you want the federal government to change, you got to throw some numbers at them. We look at it from a care gap closure standpoint, and we look at quality, we look at compliance, we look at appropriateness of ED utilization. So when I say words like fewer ED visits, fewer inappropriate ED visits, we are closing rural hospitals across this country. We are also closing rural ambulance services across this country. We had 2 hospitals closed in Missouri last year, and about a half a dozen ambulance services shut down last year and ceased to exist. Remember, we are not essential. There is no guarantee that you will have an ambulance service in your community, just like no guarantee you're going to have a hospital in your community. So this is where my nerdiness comes in. We've adopted the HEDIS measures. We believe in HEDIS measures, and it makes everybody happy. Whether I'm working with my FQHC or my CAW or my health department, we can pull the data that they need. And instead of reinventing the wheel with my business really likes to reinvent the wheel, I have pounded my fist going, it exists. Let's not start over. And so we now have 2 years worth of data. What you see in the yellow highlight is all clinic patients with a snapshot of some of the most common quality metrics. For all of you that work in healthcare outside of, probably no surprise. Sorry. In the green, you'll see the MIH cohort. Now this was blinded. I heard here, this isn't my data, this isn't so-and-so's data, this isn't Justin's data. This came from Azara Drives. This came from the Missouri Primary Care Association, which is how I met Alice, for blinded studies to go look at the quality metrics and tell us how we're doing. And the results were pretty darn cool. So we started in 2022 and then we threw it into 2023, and we were able to show marked improvement in every category for the MIH cohort. versus the entire clinic population. Makes sense, right? High touch, bubble wrap, ensure that every measure is met. So then we did it 2 years in a row, because maybe it was just a fluke. And you can see that the trend lines, while not perfect, we still in every category did better in the MIH cohort than the total clinic population. Relationships are what makes this work. I didn't know we had a Missouri Primary Care Association prior to starting this project 5 years ago. I didn't realize that I was on the front lawn speaking to the news of the MPCA about Medicaid expansion in Missouri until a couple years later I went, I've been to this building before. Why was I here? Oh, that makes sense. In Missouri, EMS is housed under DHSS, Department of Health and Senior Services. We are under the Bureau of Regulation and Licensing. I did not know that we had an Office of Rural Health and Primary Care. I did not know we had an office, a Bureau of Chronic Disease Management. We are in two separate divisions. I'm not under the healthcare division. They license and regulate us only. I now have immense working relationships with both of those bureaus because they have more work than they have people to do the work. And we have multiple projects with CP programs dotted across the state, working on different things. We are funded primarily on grants right now. We have a handful of CPT codes that are approved by Medicaid with zero reimbursement tied to them. Healthy Blue, I know I saw Healthy Blue in the room. Missouri has 3 MCOs, Healthy Blue, Centene, and UHC. UHC has invested. I have a contract with Healthy Blue on a trial project for reimbursement, true reimbursement for services, and negotiating currently with Centene on that pilot project for CPT codes with backup by ICD-10 and Z codes to show the value. We've had great support from MoHealthNet. They see the value. The government just moves slowly. We have some federal level work that is going on, but it takes the glue of the communication, it takes telling the story, and then it takes ensuring a good workforce to be able to back these folks up, to make the dream work. There are hundreds of programs across the country. They all look a little different. Our goals are all the same. Take care of the sick people, make them better, and try to drive system change. I am going to treat a diabetic patient in Washington County, Missouri, or KCMO. The quality measures are the same. The barriers are a little different. We got some spotlight during the pandemic, and that spotlight came in the form of a national survey of where you saw community paramedic programs. But also it questioned the way we've done business. We keep throwing money at the problem, and then we're really perplexed at why it doesn't get better, but we have not done a structural intervention to address change. So we call that insanity, right? Doing the same thing over and over again, expecting a different result. We believe that this is the structural intervention that can help change. CMS and CMMI said, yeah, but there's no data behind it. And we said, false. You have data. So I'm going to present, bear with me here on a few slides. So for the first time in my business's history, this little thing called COVID came along when the real surge hit, and they said, don't bring patients to the hospital unless you have to. We were housing intubated patients in critical access hospitals. We were having patients die every single day for lack of resources. So we were told, keep them at home. We said, great, but you got to pay us because we're not going to survive. So there was a CMS waiver to pay us to keep patients at home that met certain criteria. So this is data published by CMMI, and they quoted a 2017 HCUP report that said the average ED visit for a patient 65 or older was $690. We know that that is extremely understated, right? Okay, but bear with me. $690 a hit. They gave us the average rate for reimbursement for a basic ambulance was $447.56. The federal government gives themselves a 20% discount, and so our average reimbursement is $358.05 for that encounter, one encounter. We touched 55,858 patients, after they paid us, and they calculated just an ER visit, not imaging, not inpatient, not unit, they showed a savings to Medicaid, and this came from CMMI, not from anybody in my industry, from CMS. The difference was $38.5 million just during the pandemic with those 55,000 patients. And those were all patients that met low acuity criteria, sprains and strains, headaches, toothaches, or a patient that would need to be admitted to a med-surg floor for observation were being sent home and then observed in the home with communication to the facility to be able to free up beds for those who needed it. $38.5 million savings to the system with good quality outcomes. So of course this all sounds like rainbows and butterflies, and I wish to tell you that it was, but it's not. Just like healthcare is fragmented, just like rules and regulations are fragmented from all of your spaces, mine is as well. In Missouri, the laws that regulate me are vastly different than when I cross the state line into Kansas. My paramedic license here, while you're a compact state, my scope of practice is completely different, and I couldn't do half the stuff that I just listed right here. You all have reimbursement for community health workers. I don't. You go to Iowa, it's a little different. You go to Nebraska, it's a little different. You go to Oklahoma, it's a little bit different. We are fragmented. While I carry a national license, the individual states, we like local control in the United States, all of them are very different. So my caution is pushing back and going, there has to be policy change in Kansas to carry this forward. There has to be policy change in Missouri to carry it forward, but it's mostly on the sustainability side of the house. From a final reflection standpoint, we've talked money. We've studied this broadly from CMS and CMMI that shows a 50% reduction in billables on average for these patients. It's been independently done, not by us. We have HRSA validated data. We now have CDC validated data. A couple of other projects that have been funded through the MPCA, through the state Medicaid office. And the trend lines you see are all very similar for all of the programs, whether it's downtown KCMO or KCK, or Washington County, Missouri, or Reynolds County, Missouri, where I have, in Reynolds, my operation is over 800 square miles. I have no hospital, and I have one FQHC. I'm the N1 public health office. I'm the only provider 24 hours a day in that entire community. And anytime that ambulance leaves to take a patient, they are gone for a minimum of 3 hours because they're transporting to neighboring counties, or we're putting them in a helicopter at a massive bill, but that's a whole nother story. The care is the same. The issues and the specifics are a little bit different. We have policy change limitations, but at the end of the day, we're showing that we have the ability to collaborate, not take anyone's job, put the egos aside, make patients better, and save the system dollars. I would like to retire at some point as a healthcare provider. I think that if I have the ability to put you to sleep and paralyze you and put a tube in your throat and put you on a ventilator, put a chest tube in, start blood products, I think that should count for something. And that's what our folks do every day. And I will argue it's more important in the rural areas than in the urban areas because they don't have access to timely care. My folks, for my entire service area, they're on call for average 3 hours of windshield time for every call for service. Downtown in the cities, they're doing high volume, quick turnarounds, different problems. We're still rendering care. I still have to make sure that we can keep you alive for 2 hours. We still have to provide support to our critical access hospitals. I don't take care of patients very much anymore because we call that scraping the bottom of the barrel, but I worked a shift last Friday and 10-bed ER, 25-bed med-surg floor. And after midnight, I had a new grad and a GN and an RN, and a packed ED. So who's up there managing, helping run those patients? I don't care what my uniform says. We're not going to let those gals drown, right? Because I want that same respect when we're up to our ears in you know what. We support each other. Why wouldn't we do that on the primary care side or the preventative side as well? Where I was going with, you see the reduction of the emergency visits, but then the data is beautiful when you start seeing quality measures increase. You see primary care go up. You see outpatient go up. You see diagnostics going up. And so folks say, well, you're budget neutral, but the trend lines as you start looking at it is if you continued that ED care, the dollars were going to go up and up and up, but we've stopped that major bleeding. Of course your pharmacy cost is going to go up, or your outpatient's going to go up, or your primary is going to go up, because they're actually getting the care in the setting that they need. Now let's study it for the life cycle of that patient a year prior and a year post, and we're looking at about a 50% aggregate reduction with improved quality measures. Right care, right place, right time. I wouldn't take a patient having a heart attack to a community hospital. They're going to go to a heart attack center. I wouldn't take a trauma patient to a community hospital. They're going to go to a trauma center. We have I'm going to talk about 2 pilot projects that we're working on right now because I heard big behavioral health. We're doing buprenorphine initiation in the field. You heard me say that. We have a contract with Compass Health on the Missouri side to be able to do medical clearance of certain SI patients, HI patients by a community paramedic and direct transport to a crisis stabilization unit to avoid that ER, because we also believe that that's not the right place to board somebody for days or for weeks, and then transfer them all over God's green earth for inpatient care. When they're ready for help, they meet criteria, and we've had fantastic results. Our ER group and most refuse to do BUP initiation in the EDs, so we're doing it upon discharge and getting those referrals. But we actually got some Missouri Behavioral Health Council dollars to be able to get paid to take patients direct to those crisis stabilization units. And when we started to dangle that carrot, folks bit, and that then snowballed into 988 referrals coming to our CP teams and working with our community mental health workers in the field. I have one resource specialist through CMO Behavioral Health that covers 6 counties. He can't be everywhere, but he's a phone call away for a consult, or I can get on a telehealth visit and say, hey, I got a hokey one. What do you think? And ensure that these patients receive the care that they need. I am pleased to announce that I'm going from here to Kansas City tomorrow for a project that was funded and contracts signed on Monday with the Paterson Family Foundation to build up 3 additional MIH programs on the Kansas side. And so it's going to come to Dickinson. Which ones did I write down, Alice? I'm sorry. Dickinson, Norwich, and Caldwell. And there are some other programs that are dotted around the state already and starting to do things, but the Paterson Family Foundation put a 3-year project together and fronted $1.5 million for the first half. And then as long as deliverables are met, the additional 1.5 is to follow, to replicate these types of services in communities across your state. But we have some regulatory work that I'm learning is going to be fun. So it sounds like I'm going to be spending some more time in Kansas, other than just driving I-70 on the way to the mountains. I don't even know where Norwich, Kansas is, or I didn't know where any of them were. I'm like, Alice, are these really in Kansas? She went, yep, they are. I said, okay, cool. They're in Kansas. I signed on the dotted line, so I hope they are. But I welcome any questions that you have. I am an open book. My contact information is a part of the packet, right? Tammy, awesome. I have an amazing team. I'm just the one who stands up and talks and usually stirs the pot. She said I'm a disruptor, and at first somebody said that to me in a negative way. I'm like, that's the most flattering thing I think I've been called in a long time, okay? You're damn right. We need to disrupt this system. It's broken. Reach out. I have operational leaders. I have financial leaders. I have clinical folks that help. We are a business that doesn't hoard things, so policies, protocols, procedures, best practices, lessons learned the hard way. I'm happy to share. But if there's time looking, are there any questions specific to this stuff? Someone's running a microphone.
I have a question about data, patient data.
Yes, sir.
You said that it sounds like you have some frequent flyers, but what about if you're called to the home of someone that you've never been to before, and when you arrive there, they're unconscious, but you work on them and you find they have a big scar on their chest, something like that. You know nothing about them. What do you do?
That is every day of our life. You do the best you have with the resources available. I have no access to your chart in the moment on the emergent side or the non-emergent side unless you're a patient who's enrolled in our program. So if I've never met you before, I'm hoping that you have a family member that can tell a history, or we're piecing together a history based on medication bottles. You're flying dark. That is the reality of 90% of our calls that you just said.
Would it help you if they had personal health records and you could, on your way, get up to date quickly on the patient that you're coming to see?
So the short answer is yes, and of course, and we do have a project. It's with our special needs tracking program that we have implemented with, it's called our STARS program, and it's not ours, it's housed out of Cardinal Glennon. But that specific model for complexly ill children to be able to have their specific diagnoses, their care plans, their primary provider, their specialists. But the answer is yes. Right now, on the non-emergent side, so take out the emergency piece, my critical access hospital, ER is one EMR, their RHCs is a different EMR, their outpatient physical therapy is a different EMR, and none of them talk. My FQHC, I have 2 that I work with, all different EMRs. My EMR is different. None of them interact, none of them talk. So for my MIH program, we do a lot of hand-holding because I'm waiting for claims data on the back end, sometimes up to 6 months to get outcomes. And by the time you get that claims data that shows you have a problem, you can't find these people or it's too late. Yes, ma'ams.
You didn't say ma'am.
I got 2 at the same time.
And it's all right for you to use ma'am. I'm up there.
Okay.
When I started working for the local health department in 2009, we were doing urban responses with community health advocates.
Okay.
Taking that out. My question, so that I don't give a lot of context, is at that time I thought, how will this system that we're working in respond when urban starts to rise, when urban issues start to rise, okay? And I'm glad to see that this is happening, but in the back of my mind and in my heart, I know that urban is gonna fall to the wayside if they don't have a twin in you and your whole process. Do you see what I'm saying?
Yes, ma'am, I do.
I'm another disruptor. So you say it in a cleaner way.
I don't know about that. I'm just on the stage right now.
I want to know what's going to happen. You know what I'm saying?
No, I mean, that's the reality. Absolutely. And that's the importance of the state hat that I wear is my heart's in rural because that's where I live and I see those patients. But you're 1,000% right. In North St. Louis County, massive disparities. They had a beautiful program funded by BJC, shut down when it was not profitable enough. So the reality is having the conversations and the tough conversations with folks that drive CMS, Medicare, and Medicaid, because if there is not sustainable reimbursement, this is gone. It's great. It's wonderful. I love it. You see changes. That program with public health, I love my public health nurses. We do Thursday's shot day in Washington County. It's just known. We hang out with them all day long, and we go drive around for people that don't come in. But if there's not a sustainable funding mechanism to keep these folks on the road, urban or rural, they stop. And now you throw in, many of your urban systems have, so Kansas City, Kansas, fire department, super urban, right? They are a form of city government. So it goes all the way up to the mayor's office, right? The decision-making power. So the politics that are at play to keep it going causes me more chest pain than anything, honestly. Politics and money. We have champions across the state and we have champions across the country that are the urban folks. It just so happens that for Missouri, I took the hat that goes and talks to people. So if you said, who's your champion in St. Louis? I would say Melville in South County. They've got my Rockstar program. Who's my champion on this okay, I'm on the wrong side. On the east side of your state, on the west side of my state, KCMO, KCK. Fantastic people fighting the good fight. But they have to play their politics to keep their programs funded and going because there's not sustainability. You've got champions that are going one budget cycle to the next, wondering if their programs are going to stay alive. You're welcome.
I may ask a follow-up then. You've alluded to some policy-related licensure around Kansas. Can you give Kansans a head up of what needs to be different here?
I don't have all the details. I am not the SME on Kansas. What I understand is that in Kansas, you have a state board of EMS that dictates scope of practice. And so the conversations that are happening are ensuring that the scope of practice for a paramedic can be expanded upon. In Missouri, we made the lift a handful of years ago that I have a license endorsement. So my base license is as a paramedic, just like a nurse's base license is an RN, right, or an LPN. I then have an endorsement as a critical care paramedic, just like a critical care nurse. We did the same thing for the community paramedic to give them an individual designation for multiple reasons. One, to show that we are providing additional education and we had standards, but two, when we go to payers, what differentiates you? We don't have a state board of EMS that dictates scope of practice. We have our physician medical director and your service CEO dictates scope of practice based on individual community needs. Missouri's very local control, which can be good and it can be very, very bad also. But in Kansas, those are being explored currently of what is the education requirements going to be, what are the licensure requirements going to be, and what's the scope of practice going to be. Yes, sir.
Yeah, Con Olson, I sit on the Kansas EMS Association board, and pretty much everything he summarized there is accurate. The State Board of EMS is much like the State Board of Nursing and all the other
State boards of.
Yes. They regulate us as licensures and as a ceiling scope of practice for the EMT levels and the advanced levels. Kansas, it is set that the paramedic level is fairly open, but it is much like Missouri in that the local physician makes the decisions on, yes, you're trained to do it, yes, I will, or no, I won't allow you to do it. The EMS Association is going to move forward this legislative cycle in January to get some cleanup language that will help hospitals, hopefully, with some of the confusion on transfer orders that they send out, as well as fix some of the non-emergent language in which we're allowed to practice in. And part of that is step one of scope of practice for community paramedicine. So come January, if you have influence with Kansas Board of Nursing or Kansas Medical Society, please have them look at it and ask questions and endorse it, because those will be the some of the hiccups we will run into is miscommunication about that very topic, so.
And I'm going to jump on that. The project that Patterson is funding is officially the Missouri EMS Association, which I'm the president of, and the Kansas EMS Association, which this gentleman is speaking of, so that we can show unity and go, we are supporting each other. Let's not reinvent the wheel here, right? And have those conversations. But as a Kansan, the advocacy of the Kansas Hospital Association, the Kansas Primary Care Association, Nursing Association, we went through some of those. I have scars still, right, of you're taking home health jobs. No, we're not. I promise you. The nurses are going to fight you. Nope, let's just go talk to them. The nurse pracs are going to fight you. No. The language that we're seeing in Missouri Medicaid right now around CPT codes are non-physician licensed healthcare practitioners. And that's what we keep pushing. We're not here to take anyone's job. We're just here to support your system of care. Thank you. Alice always has a question.
Mine's really not a question. It's more of just some additional information that I just think helps with the context of this conversation. Justin has already said there are health centers in Kansas that are doing this work. Yeah. And they're funding it through grant funds. They're funding it through revenue they generate through some of the programs that they're running. So these 3 other locations that he's talking about, we're super excited about that. The other thing I would say is that we need to make sure that, as he said, we're partnering with those various groups so that when that legislation starts to come through, we're all speaking the same language, we're using the same talking points so that we can continue to push this transition through. I will also say that there are health centers in Kansas that have mobile units. They are not the mobile units that Justin is describing. We're talking RVs. Camper-sized things, bus-sized things. So they're working to try to get that mobile access more across the state. And the state health department has just recently made mobile a place of service so that they can bill for health care services provided. It was just outreach. Now they can be billing for medical services and dental.
And our clinics are the same. So our billing is only on time. We didn't want to take anything away from our health centers or any of our partners. So that blood draw, they still get to charge for. The telehealth visit, they still get to charge for. Ours is simply a reimbursement based on our time in the home, not on the specific services. There's also federal legislation right now that is filed on the topic. House Resolution 8042 was the Community Paramedicine Act of 2024. If you're really, really bored, if you look up treat, no transport, treatment in place, treatment, alternate destination, those are all themes that, because heaven forbid we all get on the same page and call it something the same. Those are all key things that are being talked about at multiple state and federal levels. But Missouri is here as a neighbor and as a friend to support this side of the river, or in some places, this side of the line down the middle of the street that makes no sense to me. So thank you very much. It was a pleasure.